Jarvis. I've titled this webinar, The Future of Community Behavioral Health, with a picture of the Jetsons to help us realize that the future may look a lot like what it used to look like in the past, or a lot like things that we've never thought about before. It's up to you to sort of do that assessment, but we're just going to dive in and have some fun today. If you have any questions or comments, probably the best thing to do is to type it into the chat box during while I'm talking, and then if you want to grab me, though, please just speak up and ask a question or make a comment. As you'll remember, for those of you that were on last week, we started out talking about how the role of a carve-in compared with a carve-out and the things we need to be on the lookout for. We're going to be going down to the provider level today and thinking about how is the provider system going to change. And the next webinar, what I want to do is talk about how providers, what are some options for a provider alliance in terms of providers working together to support the kind of picture that I'm going to be painting today. Thanks, everybody, for sending me your comments about what keeps you up late at night. That was really helpful. So hopefully you remember this little logic model of how to fix the healthcare system, where we're starting with the sick care system because most money is flowing only after you get sick. And the whole idea of seed funding to deploy high-impact interventions to interrupt the supply to the sick care system so we can free up additional money to right-size the system so that we achieve a health system as opposed to a sick care system is part of how you think about the world now. And one of the questions as I think about this little logic model is, so what does this have to do with behavioral health provider organizations? And being a CPA, I think about it in terms of numbers. And so I'm thinking about these three columns from California from an analysis that a firm did a few years ago around everybody that was in fee-for-service Medicaid, which they call Medi-Cal, and that they were going to be moving into managed care. And they did this really brilliant thing where they said, let's look at everybody who doesn't have a serious mental illness and put them in the yellow column, and let's look at everybody who does have a serious mental illness and put them in the orange column, and let's compare the differences. And so what we found was that about 11% of the folks who were in this pool of 1.6 million had a serious mental illness. And what really blew people away when this report came out, because nobody had ever run these numbers for California before, is that the average person who didn't have a serious mental illness had $2,681 a year in health and behavioral health costs, the Medicaid costs, while somebody who had a serious mental illness cost 5.4 times more money at over $14,000. And when they broke out the kind of things that were going on for the folks with a serious mental illness versus those without, they found, well, 3.5 times higher rate of diabetes, almost 4 times higher rate of heart disease, and 3 times higher rate of respiratory disease, etc. So very serious health conditions at a much higher rate for those with serious mental illness, which we all have read about and heard about and seen some in the literature. And that translated into higher inpatient admissions, higher emergency room visits, higher primary care visits, higher medical specialty visits, almost 10 times higher the rate of medical specialty visits. And so what we know, this is like, it's really important for this to become our mantra, that people who have serious mental illness have higher rates of serious health conditions, have higher health care costs, in addition to dying on the average 25 years earlier than the rest of the population. And so this is really, really important for us to never forget for a moment that the folks that, those of you that serve adults are working with, the system isn't working for them, and this is evidence to show that it isn't. And for those of you that are working with kids, unless we do something different, this is what some of their future looks like. And so, and the reason why this is so important for behavioral health providers is because if you're not thinking about the whole health and the total health care expenditures of the kids, the adolescents, adults, older adults that you're serving, you're not going to be seen as very relevant for the future. So the way behavioral health providers fit into this is into the previous picture, is that a lot of the folks that you serve really are the very expensive folks in box 3 where we need to wrap care around them to help them stay out of the hospital and stay out of the emergency room. And the problem is that you've been being funded to metaphorically treat from the head up only and ignore the rest of the person. So that's some of what we're going to be talking about today. And again, please feel free to add questions, type in the chat questions or comments, and then we're going to stop a few times for verbal questions and comments. So in this world where there's a recognition that actually people, not just people with serious mental illness, but people with more mild and moderate behavioral health disorders have higher health care costs and more complex health conditions, this has become like a really big deal to everybody in the whole healthcare system in the country. It's what the heck do we do to do a better job around the whole health of people with behavioral health disorders? So for folks that are really been thinking about this for a long time, this is actually music to many of our ears that this is becoming a really big topic of conversation. So the near future, behavioral health is going to be everywhere. And so we're going to see behavioral health in primary care. So this is stuff that you've heard about for years and you may be involved in to address the needs of persons with mild to moderate behavioral health disorders. And behavioral health specialty centers of excellence, which is a partner with medical homes to support individuals with complex behavioral health conditions. And most of you, let's see, you're neither, because there is no designation yet of a behavioral health specialty center of excellence. So you're not able to officially call yourself that. And for most of you, you're probably not providing tons, you're probably not locating tons of your staff in primary care clinics. But what's going to basically happen is every primary care clinic in the country within a relatively short period of time is going to basically be required to have behavioral health clinicians working in those primary care clinics. Part of this is being driven by NCQA, National Committee for Quality Assurance, Patient-Centered Medical Home certification standards. There's new 2014 standards that have come out for primary care clinics that really push a lot more responsibility onto the primary care clinics to assess, treat, and monitor people's behavioral health conditions. And so basically what's going to happen is 80% or more of behavioral health in the not too distant future is going to be treated in primary care, and 10 to 20% will be treated in specialty care. And most folks with behavioral health disorders, most folks will be assessed early and engaged in care, because not doing that results in higher health care costs. It's follow the money. It's follow the money, follow the money. And it's just amazing to realize that people with behavioral health disorders are of such special interest. So let me talk about the new workflows, because I know everybody loves Visio diagrams and workflow diagrams. Just kidding. So let's pretend that I moved down to Southwest Washington, and it's the not-too-distant future, and the first place that I go is to a primary care clinic. And let's say that I have a behavioral health disorder of some sort. What's going to happen, if it doesn't happen already, is Dale's first visit to the primary care provider, the PCP, includes a behavioral health screening by the primary care provider. And if there are possible behavioral health issues, the primary care provider will do a warm handoff in real time, right while I'm there in the clinic, to a behavioral health professional to do a full assessment of what might be going on with me, and the languaging will be such that it will be inviting, and I'll be motivated and interested, or at least curious, to have this visit with this person who will have any of 27 different titles, probably in the beginning many that are rather innocuous to destigmatize this whole trying to get Dale engaged and to figure out what's going on. If I need behavioral health services, there's going to be one of 3 doors that are offered to me. Let's say there's going to be options that are offered to me, and I'm going to pick one of 3. And this is going to be patient choice centered. The first, if I have a low to moderate behavioral health need, some of this may seem familiar to you for folks that have worked with the Disability Lifeline MHIP project. I'm going to use level 1, 2, and 3 as descriptors. I might be enrolled in level 1 care. And most people with behavioral health disorders are going to fit into the level 1 box, which is I have a mild to moderate disorder where I'll be case managed and served in primary care by the primary care provider and a behavioral health coordinator with help from a consulting psychiatrist and other clinic-based mental health providers. But if I have a high, moderate to high need, I'm going to get referred to level 2 care, which is specialty care, which is referred to what I think is going to be called a certified community behavioral health clinic or a behavioral health center of excellence. The primary care provider will continue to provide medical services. The behavioral health care coordinator in the primary care clinic will maintain the linkage between the specialty provider and the primary care clinic. And this will be a time-limited referral with expectation that the care will be stepped back to primary care. So in the GAU Disability Lifeline project, these were 6-month. These have been 6-month authorizations when this project was before healthcare reform hit and those people all moved to Medicaid. The third door that will be offered to me is if I have a high, moderate, or high need where it's not a time-limited referral because I have a serious mental illness that is more than like a 6-month thing. I would be offered the choice to be transferred to a level 3 behavioral health specialty care, where basically my health home would shift over to the behavioral health clinic, who would be, and that clinic would be responsible for meeting the whole health needs, either by having a primary clinic embedded in the mental health center, or having that behavioral health clinic have such tight partnerships with the one or more primary care clinics in the neighborhood that my care would be case managed and overseen by the folks working in the behavioral health clinic, but I would get my primary care from a primary care clinic that would basically be virtually the same, it would feel like the same organization. And so this model is, this workflow is how it unfolds if my first visit to the community is to my primary care clinic. Now, if we think a little bit further down the road and we say instead of being 61, I'm 6, there's a similar description, or 3, there's a similar description where there would be screening, developmental screening, that an assessment that goes on, identification of any issues, including behavioral health issues or health behavior issues. And the idea is that I would be, if I'm a little kid, I would be equally invited into the right kind of assessment and treatment to help me with whatever's going on, so that we actually prevent me in 10 or 15 or 20 years from having what's going on in my life and in my brain turn into a serious mental illness or a serious substance use disorder. So we're actually anticipating that this model will literally reduce the prevalence of serious behavioral health disorders because of early screening, early intervention, early treatment. So let's see, that's a lot of words. I want to say one more thing and then stop and see if anyone has any questions or comments. There's integration, there's 2 doors, and I'll talk about door number 2 in just a couple minutes. Now, what's interesting is that we're going to see, like right now what happens in primary care is that there's one, like a social worker that works in a primary care clinic, maybe part-time, maybe full-time. But we're going to see a much richer team of behavioral health providers in the primary care clinic of the near future, because these folks are so important to addressing the whole health needs of the patients. And I can't tell you how many primary care docs I talk to that say half of my visits are really behavioral in nature. And I don't have training for this, and if I really had a team to be working with me, I could use my time much more efficiently. I could go home for dinner and be at home for dinner more nights during the week, and I would get woken up when I'm on call less nights because I've got this team supporting me doing work. And if you look at who the team members are going to be, this is just a guess of some of the positions. We're going to see behavioral health consultants, behaviorists that are helping with health behaviors, as well as brief treatment. We're going to see behavioral health care coordinators who are doing ongoing long-term care management for people with for health disorders and health conditions. We're going to see peer counselors, / health coaches, / medical assistants. We're going to see treating therapists. We're going to see consulting psychiatrists, mostly via telemedicine and telephone. But when these clinics, primary care clinics, start getting, as they continue to evolve, it's going to be team-based care with these folks supplementing the rest of the medical team, really spending a good chunk of, like if you take all the hours of care that goes on in a primary care clinic today, at least 30% of those hours are related to behavioral health or health behaviors. And it's going to be at least that much tomorrow, but tomorrow there's going to be positions that are going to be paid for, that are going to be cost-effective, that are going to actually help reduce the cost of the total health expenditures for those patients, that will support these costs and allow physicians and nurse practitioners and physicians' assistants to be able to focus on what they really know how to focus on. So I'm going to stop now for just a moment and look at my chat message and see what kind of questions people have. So I'm going to just go into cone of silence for 15 seconds while you think about rich and exciting and provocative questions to ask me. Cone of silence.
Jump on, go.
Okay, so we have some questions from the Peanut Gallery. Go ahead, Peanut Gallery.
It's us.
Is that me? Okay, Dale,
Yes.
This is Richard Randolph again. I hate beating a dead horse because I don't think it's dead yet. And the stuff that you brought up about the people with behavioral health disorders having much higher utilization of medical care is directly traceable to their use of tobacco. The general population in Washington right now, the general population's use of tobacco is among the lowest in the country. It's down to 16, 17%. It might even be lower than that now. In behavioral health populations, it remains at anywhere from 70 to 90%, depending upon who you ask. And of the people that come into our agency, we always ask them, do you smoke? Would you like help quitting smoking? At least 3/4 of them who do say, yes, we would like help quitting smoking. I think this is your target group. And this is why I made the point last time that behavioral health providers should be credible to treat people who have tobacco addiction. And if we don't do that, we're failing our clients because they do die 25 years ahead of the general population. You're very correct about that. And the reason why is because they use tobacco. The tobacco makes them require twice as many psychiatric meds as non-smokers because the tobacco blocks the action of those medications. And you have every imaginable physical ailment that in our society directly traceable to the people who use tobacco. And the numbers of people that die every year, and this is shocking to people who don't know it, it's approaching 500,000 people in the U.S. who die because of tobacco use. And many of them are our clients. And if we can't convince the people that are writing these RFPs to the insurance companies that we need to be at the ground zero of treating these folks for their tobacco addiction, we're absolutely missing the best bet that we could have because they're spending all their money on quit lines and telephone counseling that do no good whatsoever. And so this, to me, is one of the more critical pieces that we have to make sure is included in the RFP and that we get paid to do down the road because it'll keep a lot of us afloat, especially in an era where they're going to have behavioral health specialists in primary care clinics. And the standalone chemical dependency and mental health agencies are going to be really in a struggle for survival if we don't find other means of revenue. Plus, we'd be best at doing this. So I can't state strongly enough how strong I feel about this, that we absolutely have to do this. And if we want to make a dent in the high utilizers, we have to address their tobacco use, or it won't happen, pure and simple.
So let me riff on what you said from a little different angle in support of your comments. So I'm going to go back to my lovely little workflow, and in this workflow, let's see. I'm still up at the top of the screen, and where I'm at is I'm coming in, and my doc does a screening, and clearly there's a whole bunch of stuff going on with me. And the doc, okay, so let's just say that the doc has enough of a conversation where he thinks I may have a drinking problem. He thinks I may have psychiatric DSM-4 kind of issues going on related to mental health, and he sees that I have a smoking problem. And so let's just say that I may have major depression, I may have a serious drinking problem, and I have a smoking problem. Let's pick those three. He is going to, so we're going to go visit, we're going to do an assessment by a behavioral health professional, and there's a couple scenarios that are kind of scary for that doc, and one that isn't at all. The scenario that isn't at all is there's a dually licensed person with co-occurring disorder treatment expertise who really understands tobacco addiction as part of all that. And the doc walks me down the hall Julie's office, who really can think about the whole meal deal. And then there's another scenario where the doc has a mental health counselor and an alcohol and drug counselor at the end of two different halls, and he doesn't know which hall to go down because these people have different competencies, but I've got three things going on with me. And what's really important is the total health care expenditures are going to drive, managing the total health care expenditures by helping people improve their health is going to drive the behavior of an enormous number of decisions for the good for patients. And these clinics are really going to, and everybody in the healthcare ecosystem is going to be thinking about integrated care and staff that have behavioral health competency as opposed to just mental health or just knowing about alcohol but not drugs, or alcohol and drugs but not the tobacco part of the substances. And there's going to be a lot of attention placed on all of these, and they're going to be looking for solutions that are integrated at the behavioral health level, not fragmented. So I wanted to just make that point, tagging on to Richard's comments that I agree about. Other questions?
Dale, this is Pat from Children's Center. I just want to piggyback on what Richard said about tobacco use. I think in the kids' world that's an area that's often neglected, and we're seeing kids at a much younger age who smoke cigarettes regularly. And that when we get notes from pediatricians, that's rarely screened. We rarely see that in their assessments when they refer kids to us. And the state, they have this quit smoking line, or you can get counseling. They won't do it for kids. They won't give a free nicotine patch for kids. Our psychiatrists end up prescribing medication to help them to quit smoking under the guise of another mental health disorder. So it's something really that whatever is in the adult population, it does begin when they're kids, and pediatricians have to be educated about that.
Yeah. So, go ahead.
This is Kirby. One, because I also wear a public health hat. Public health has traditionally gotten the tobacco funding and not really used it, in my opinion, in a very concentrated way. And so even the services that you all are talking about are not funded in all counties. They're not funded across the board in Washington State through public health. And so I think that public health needs to be another player at this table.
Yeah, good point. So there's a question about how do we include more behavioral health services and other kinds of services when we don't have room or time for what we do now, especially in rural clinics, and especially related to the space, thinking about this as a bricks and mortar question. And I think that right now, primary care represents about 5% of the healthcare dollar. 5% of every dollar that's spent in healthcare is all that goes to primary care. And what's happening around the country is there are forward-thinking health plans that are doubling that amount. So they're basically doubling the budgets of primary care clinics. And so we're talking about a 10-year plan. We're talking about this not happening overnight. We're talking about this incremental. We're talking about the telemedicine becoming much bigger, virtual clinics that are web-based and online appointments. There's all sorts of innovative, creative solutions that are going to be coming to the fore, and it's not going to happen overnight. And we're going to have to solve the bricks and mortar problem only as quickly as we can solve the bricks and mortar problem, and that is one of the limiting factors. So I don't want to undercut it. I do want to grab something and show you. Hold on just a sec. to underscore how big a change we're going to see coming. So improving healthcare is billionaire Peterson's next mission. Peter Peterson, the Blackstone Group co-founder, so this is one of the large equity capital, venture capital firms, largest in the world, is now taking aim at the $800 billion of waste in the healthcare system. And his foundation, the Peterson Foundation, is announcing a $200 million offshoot next month, the Peterson Center on Healthcare, that includes Bill Gates as a board member, among other big names, to bend the cost curve by basically working on triple aim initiatives. And what's happening is that there's all these people who have a really big stake, either philosophically or philanthropically or bottom line-wise, that are bottom line-wise are being, excuse my French, screwed by the healthcare industrial complex, that are starting to realize that we have to work together to fix the healthcare system. We have to get that new theory logic model in place. We have to flip the resource allocation triangle. And it's going to be really curious to see how these ideas filter down to organizations like yours, and how organizations like yours go become best friends with some of these folks as you really work on creating a true health system and want to get support for that. But this is a whole 10, 15-year project. It's not going to happen overnight. It's really actually incredibly exciting if you can just keep breathing. So I'm going to talk a little bit about the roles of Behavioral Centers of Excellence, BHCOEs. So when clients with behavioral health disorders cannot be managed in an advanced primary care clinic, even with those additional staff, they're going to need that Behavioral Center of Excellence, which is the picture that I was talking about. And let me show you another workflow that'll be a lot quicker to go through, but just to paint the other picture that's going to unfold. So here, I moved on to your neck of the woods. My first visit is not to a primary care provider, but to a behavioral health provider, because I've been struggling with those conditions I was talking about, major depression and alcohol abuse and tobacco abuse for a long time, and I've been going to a clinic up in West Seattle, and now I moved down there, and I heard about your clinic, and I go there, and the first thing that happens, what happens in my first visit is you do a health screening, and you say, oh wow, it looks like you've got a bunch of health issues. Do you have a primary care provider? And if I do, then you say, oh, we're going to become best friends. We need to connect up with your primary care provider. We need to get a release of information in place. We need to be able to create a virtual care team and a virtual care plan. Or if I don't, who do you want? Let us help you get a primary care provider. And do you want us to be your health home? And if the answer is yes, then I sort of go through that door. Or if the answer is no, I find my own other primary care provider, but you're still linked at the hip with that other primary care provider. The point being that it doesn't matter whether I go in a primary care door first or a behavioral health door. Both folks are going to be looking at my health and behavioral health needs and making sure that I have as close to seamless whole person care, even if it's provided by multiple organizations, as much as possible. So I want to just do a little Okay, so I'm thinking about behavioral health centers of excellence now, and I'm going to start weaving into what that is, what it means, and I want to start with, I want to take I want to think about you all being on a journey to becoming behavioral centers of excellence, and I'm actually assuming that you've already started that journey, and you're interested in accelerating that process. So let's take a question from a potential customer. My life is not working for me right now, and I know it's related to my mental health condition and my drinking, made worse by my diabetes, high blood pressure, and weight problem. Every place I go to for care only treats one of my body parts. They ignore me as a person and end up doing a crappy job. Would coming to your clinic look any different? So that's the kind of question, that's the kind of activated patients we're going to be helping. We're going to be working with folks so that they become activated and engaged and empowered enough so that they start asking those questions and looking really hard at every place they go for the right answers. And so as you think about whatever you do now and revise the words here to fit the population that you're serving, whether it's kids, adolescents, adults, and older adults, there's a version for each of those, and for all sorts of other demographic characteristics. Would coming to your clinic look any different? Is a really, really important question for this group. So I want to shift gears and talk about behavioral health centers of excellence through the lens of the new legislation that was passed by Congress. Some of you were on a call where I talked about some of these topics, but this is sort of, I think, the first official communication that I've had with you. So on March 31st, Congress passed what's actually called Protecting Access to Medicare Act, which was H.R. 4302. And embedded in that H.R. 4302 was a piece of legislation called the Excellence in Mental Health Act. And what it does is it creates, for the first time, a definition of a certified community behavioral health clinic. It provides $25 million in planning grants. It provides $1 billion in funding that's going to go to 8 states to support a two-year demonstration project around these certified community behavioral health clinics. And it changes the payment model so that states participating in the future, what we're basically doing is we're moving from lack of parity in the delivery system because we have FQHCs that have certain benefits and responsibilities and money that behavioral health clinics don't have, to a situation where there's a sister system that's in the process of developing. It was passed by Congress. It's called Certified Community Behavioral Health Clinics. It's the sister system to FQHCs for addressing the needs of people with serious emotional disturbances and serious mental illnesses. And there's money in a certification process that's coming your way, and I want to make sure that we spend a couple minutes talking about that, even though it's not coming for a couple more years. So it's really creating a good housekeeping seal of approval. It creates a parallel structure with FQHCs, I want to say that a few times, containing a single set of national standards for behavioral health organizations. CCBHCs are going to need a full range of behavioral services for individuals with serious mental illnesses and serious emotional disturbances. They're going to require the screening and monitoring and managing of chronic health conditions inside behavioral health clinics. And they're going to require the provision of behavioral health care, i.e. both mental health and substance use disorder services. And there's a whole bunch of new money that has been passed by a very contentious Congress to support this experiment. And so what you need to know today about these puppies is that criteria for community behavioral health clinics are actually coming either later this year or early next spring. There was a listening session that SAMHSA did the week before last, gathering feedback from folks about the criteria in the law and what should go into this official set of regulations. What's going to happen is in 2015, states are going to apply for a grant to do planning and preparation to certify clinics in the states that get the planning grants to be certified as CCBHCs, following the federal criteria, as part of the process of developing an application to be one of the 8 pilot states that are going to get this extra funding. Like I said just a second ago, they're going to need to certify the clinics that meet the standards, and then 8 states will be selected to participate in the 2-year pilot, and we think those states will be selected before President Obama leaves office, which is January of 2017, which sounds like a long way off, but it's really not. And like I said, the CCBHCs in those states will receive a whole lot of additional funding to provide, to test out this pilot, including providing services to assess, monitor, and manage people's chronic health conditions. So if you think about the 3 doors, or the 3 levels, where the 3rd level is specialty behavioral health clinics that manage people's chronic health conditions, that's what we're talking about here as part of this new legislation. And so what we're really envisioning is truly a system of care that's integrated, and the feds are really pushing this big time. So if we look at the work that we've been doing at the National Council around Behavioral Center of Excellence definition, I'm going to spend a few minutes talking about the definition and the criteria, and then take a couple minutes more and see what kind of questions and comments that you have about CCBHCs and BHCOEs. So here's what we came up with. A Behavioral Center of Excellence, and I know that some of you have, maybe many of you have seen this, is known by the entire community as a great place to get care and a great place to work. It offers easy access to affordable, comprehensive care for persons experiencing behavioral health issues. Clients experience respectful, self-directed, team-based, and holistic care that addresses their problems, and achieves outcomes important to them. It's created by each staff member who has a heartfelt connection to the community and the people they serve, based on a deep understanding of trauma, best clinical practices, and an unshakable commitment to resiliency and recovery. So if you just stop and meditate on these half-dozen bullets and the words that are after each bullet, it describes a place that people with behavioral health disorders would feel really held by, would feel really supported by, would feel like they have relationships with real people in these organizations that are really committed to them, and talk about what's the foundation for building resilience and achieving recovery. I think what's in these words really speaks to this. And so we have a set of elements, and we also think about centers of excellence where you're seen by the community as a great place to get care and work as the Mayo Clinics of behavioral health in your community. So we've identified 5 elements. We think they're going to evolve over time. It's not an exhaustive list, but we really think that organizations will not be viewed by the community as a great place to get care and a great place to work without getting high marks in these 5 areas. And so one of the things that we're going to be doing is putting together an updated self-assessment tool, gathering information on how well you think you're doing in the areas related to these 5 elements, as well as the areas related to the Certified Community Behavioral Health Clinic status. So we're going to, because we have some idea of what the criteria are for that, even though they haven't been published by SAMHSA, they are, and there's a bunch of stuff in the law, and we're going to be working with you to assess where your strengths and your weaknesses are individually and as a group. But let's take a couple minutes going through some of the elements, taking a break, fielding questions, and then continuing on. So the 5 are easy access, world-class customer service, comprehensive care, excellent outcomes, excellent value. So I want to pose another sort of question as we think about somebody from the outside who doesn't really, is not part of your ecosystem, trying to figure out who you are and whether you're what the future needs. And so this is an investor. I know that you run a behavioral health provider organization, but aside from hearing that you're doing great work, I know nothing about your organization. Can you give us a pithy overview of who you are and what you do? P.S. You get extra credit if you can tell me what movie I acted in as a villain character, Hugo Drax. But that's just that's not as important as the first 2 bullets. But be thinking about the answer to that question as well. So this is a really interesting question, because what you have is somebody who's it should also, the subtext is in how you're helping fix how you're being part of the solution and not part of the problem. I'll be sending these slides out shortly after the webinar. So, easy access, be there when I need you. A BHCOE is known for ensuring that new and continuing clients are able to get the right care at the right time in the right setting by the right provider. Sounds great, but that's easier said than done. What about chronic underfunding, high caseloads, high no-show rates, staff turnover, need to drop everything to respond to my clients in crisis, overwhelming paperwork? It's really easy to say that you guys have great access, but it really requires a lot of re-engineering, and it's no coincidence that this is a major National Council initiative supported by MTM Services, who have been doing a lot of work around open access. So easy access is really important. It's the starting point. If folks can't get their clients, patients into your care, then it's really, I'm thinking about all the new expectations that from health plans and direct primary care providers, it creates a really big problem. So let's just play with a question. I'm not going to have you respond to this. This is just for you to think about, and but it'll become part of our assessment to give you a little preview. What is the status of your organization when it comes to same-day access? We provide it. We're working on a rapid access initiative. We're seriously considering a rapid access initiative. We think this is not a vital few initiative, none of the above. So these are the kind of questions that we're going to be asking you as we move towards the self-assessment process. Let me talk about world-class customer service. Field some questions. I see people have written in some questions, and then we'll finish up and talk about what's next. World-class customer service is built on a culture of staff and client engagement and wellness. That's a really interesting sentence. Kind words can be short and easy to speak, but their echoes are truly endless. Mother Teresa. Someone calling themselves a customer says they want something called customer service. What the heck is an extraordinary customer service experience? Well, one of my colleagues says, well, I know when I don't have one, all of us can identify this. I walk away feeling like they really missed the boat. So this is Carl Clark, who's the CEO of the Mental Health Center of Denver, who has been working on this Behavioral Center of Excellence project. World-class customer service. Job one. So this comes out of the Center of Excellence piece. Create an organization that's a great place to work and is made up of individuals who believe deeply in resiliency and recovery. Where all staff are focused on their own physical and emotional wellness in order to support a journey to wellness for their clients. I want to riff a little bit about this slide with the next one. If you haven't seen this article from the New York Times, you should Google it and just spend a few minutes reading it. Why You Hate Work. It's from May 30th of this year. And I just want to read one quote from it about the importance of employee engagement. The way we're working isn't working. Even if you're lucky enough to have a job, you're probably not very excited to get to the office in the morning. You don't feel much appreciated while you're there. You find it difficult to get your most important work accomplished amid all the distractions, and you don't believe that what you're doing makes much of a difference anyway. By the time you get home, you're pretty much running on empty, and yet still answering emails until you fall asleep. So this is the life that we lead, many of us lead in modern America, and it really causes burnout and, well, there's a whole set of consequences, turnover, and this is not about behavioral health organizations. This is about the whole American economy. And what folks like Tony Schwartz are saying is we need to fundamentally rethink our workplaces. And I think it's going to be really hard to create behavioral centers of excellence without really tackling this employee engagement piece. So here's my third and final question. And this one is from a potential staff related to the Center of Excellence stuff. I'm a social worker, got burned out, and left community behavioral health for a great job at the Gates Foundation. So I thought. It turned out to be more of the same. I was a widget, didn't feel valued, and had no connection to the mission. If I come back to providing direct service at your organization, will my experience be any different? And so this is a really big issue that I think we're going to probably spend a good chunk of time talking about as we go through the technical assistance piece. I want to say one more thing about this and then shift gears a little bit and take your questions. Everyone at the center is focused on me, from the front desk person to the psychiatrist. I sense that they really care about me and what I need. It's like I'm in Nordstrom's with those extra personal touches and people who fix anything that arises, any problems that arise. So this is the kind of feedback that I've gotten from folks as we've been working on this Behavioral Center of Excellence project. Let me stop and go into my cone of silence for just a few seconds and see what kind of questions that you have before we go on. So I'm going to count to 15 and then come back at you.
Are you off mute?
Yeah, it's green. If it's green, we'll go.
Colorblind. There it is.
Okay.
I have a question for you, Dale. This is Richard again.
Please.
Around this issue. Right now with Washington Medicaid and county sales tax, we're able to bill for client outreach, and we also have a category called agency outreach. So when we get a phone call from somebody who's interested in becoming a client, we need to have somebody available to talk to them about what the process is and how they can achieve service delivery at ChangePoint. And if we end up with an RFP or a payment schedule that doesn't include outreach, I think having the opportunity to do what you're talking about in this last couple of slides is really going to be harmed pretty dramatically, because right now we can bill for those. And so the clinical supervisor who does all the assessments can spend half an hour on the phone with somebody who's looking to access treatment somewhere and can answer these questions about what they can expect to get when they come to our agency. Obviously, we can't talk about what they can get at other places, but we need to have the time to invest to convince sometimes recalcitrant clients to, yes, come in today, come in right now. We'll start the process. We'll get as much done as we can. We'll finish it up tomorrow. And so that's what we strive to do at our place. And since we changed from an appointment schedule that we used to do, where sometimes people were scheduled out a month for an assessment, 3/4 of the people who had to wait a month for an assessment never showed up unless they were court mandated, and sometimes even they didn't show up. But the voluntary client in chemical dependency needs to be responded to the minute that they call. They need to get an invitation to come in, or the likelihood is that they never will come in because the crisis will pass by the time the scheduled appointment occurs, or they'll be in jail, or they'll be living half a continent away. So protecting
ourselves, we have to make sure that the state connects the dots. The little project that we're working on related to contracting, we need to be talking about the importance of funding, taking the whole concept of outreach and having adequate funding for that, continue for the CD community, and make it available to the entire system of care. And we need to really be able to, we need to get the state to really support this going after becoming one of the 8 pilot states to work on certified community behavioral health clinics, which when you look at the services, outreach and engagement are part of the required services, and that's going to be in the federal definition. But there's going to be this period of time. I had a really great time reading what's keeping people awake at night, and one of the questions or comments that people made is, are we going to have a period of time between when all this stuff really hits and becomes a requirement, and is it going to be 2 years before all this stuff shakes out, and in the meantime are we going to be like driven into bankruptcy? is a really important question that we need to be advocating doesn't happen.
Well, it's very possible, given that the health insurance companies are bottom liners, and they're not used to paying for intangibles like outreach, and the state needs to be on the side of that, because the DBHR saw the importance of doing this and funded it for a very long time. And if they don't require that the health insurers do that too, then they're not going to even get the same outcomes we have now.
That's right. That's right. So that's why we've got our little work group, and we're going to be working to aggressively push these ideas.
Good.
Let's see. I'm gonna jump ahead to the last slide and then come back. I want to ask you a few questions about our process. So we're going to be providing feedback to the Healthcare Authority on the early adopter procurement and contracting. And so the work group is getting organized. I've got the names of people that have volunteered to work on that, and I'll be reaching out to them right after Thanksgiving. We're going to be doing additional webinars. Like I already said, the next one that I want to do is on provider alliance models to consider for how you guys continue to work together. And but I want to ask you right now, from the perspective of holidays and how busy you are with other things, like we've done two webinars during the week, back-to-back weeks. We're going to be focusing on the feedback for the Healthcare Authority piece. How many webinars do you want in December is my question. Do you want to do a couple and sort of combine our work, sort of split our work, so we're doing 2 more webinars next month and focusing on the feedback to the state? I'm assuming that during the week of Christmas, it doesn't make, I'm just talking aloud for a second here, that it doesn't make sense to, oops, Alaska Airlines, Hawaii, oh, not going there. Nice idea. I'm assuming we probably should skip the week of Christmas and the week after Christmas. So that really gives us 3 weeks in December.
December or January?
Yeah, so let me, before the rest of you chime in with your answers, let me just quickly go through. So we're going to do, what I want to do is start the provider assessment process right after the first of the year. And then I want to do I want to bring back the results from that assessment and do a face-to-face meeting with you. And I'd really like to do that in January. And so that we can use the results of that assessment to do some face-to-face planning together, some face-to-face identification of individual and group consultation that we can do via webinar and face-to-face, and really build out a robust technical assistance for you that will be tailored to what comes out of the self-assessment. So what I'm looking for is for us to build the assessment in December, get feedback from some of you on what we might be missing, push that out right after the first of the year and move down the road fairly aggressively around some of this stuff because time's a ticking around all this stuff. So that's what our current game plan is. And so we have one vote for 2 webinars in December. Does anyone else want to suggest a different number?
Hey, Dale, it's Bunk Morin. You know, I'm open to whatever number of webinars are necessary. I think to frame my answer the most helpfully, my curiosity goes to the bullet point for provider alliance models to consider and what kind of time frames, depending on which route that could go, are there time limits? So like say we all agreed we wanted to go with one model versus another, is there something that would have to be done by the end of January to assure that it's still viable, or because that would influence my decision about how many webinars I would think.
So let's see. What I want to say about that is you guys are going to be most successful if you carefully move towards finding a way to really support each other and become more aligned and potentially take on risks together, like I talked about on a phone call that I did with some of you before we started this project. And you shouldn't rush that process, but that you can start acting together as if you're more aligned than you sort of legally are sooner than what you can start acting as if. So let me just make up an example. Let's say that you decide that you're going to start a risk-bearing and like a behavioral health ACO, for lack of a better term, accountable care organization. That's going to be a legal entity and it's going to contract with directly with health plans on behalf of you, so that you're contracting as a group as opposed to individually. So I'm just making that up as that's one of the examples that we'll be going into detail about. There's a few other possible models, several other possible models, but let's just say that you pick that one, and let's just say that the early adopter health plan contracts are going to go live in early 2016, but the health plans are going to be negotiating the contracts shortly after they get picked, which will be like late spring, early summer of 2015. You could, I wouldn't expect you to have your ACO developed by next summer. What I would expect is that you'd be in process, but you could still start negotiating with the health plans as a group as opposed to individually if you went down that path. And so my timing is the health plans aren't even going to know who the health plans are until late spring, early summer. And you basically have a year to be actively working on this, and whatever you decide to do, start acting as if you're whatever you're going to be when you grow up, if you will, by next summer. And so I don't think there's a need to rush anything now except to feed back to the Healthcare Authority and the early adopter procurement and contracting.
Thanks. 2 webinars.
2 sounds good. This is Joe from Lutheran Community Services.
So what I'm going to do is I'm gonna let's see. Is one last question about this? Is there a better day? I think the week of the 8th and the week of the 15th are the best weeks for me. So because I'm going to be out of town next week, and I want to do thoughtful planning on the next. I may end up doing 2 webinars on the provider alliance models, and I really want to get that well organized and get it materials in advance. So during the weeks of let's see, today is Tuesday. Is there a day of the week that's better or worse for anybody?
Dale, this is Pat. Wednesdays are typically not good for me. Wednesday afternoons.
Okay.
Tuesdays at this time don't work for me also.
How about later on Tuesdays?
That would be fine.
So what if we said like Tuesday from 2 to 3:30 or 2:30 to 4 on the 9th and the 16th? Okay, silence is a great, for me it means sounds good.
What time did you say, Dale, on the 9th and 16th?
Tuesday, 12/9. Oops, sorry, hold on. 16, 2:30 to 4 p.m. is what's on the table right now. Okay, so hearing no and seeing no, this is like huge problem. I'm going to just put these in the calendar and get the announcements, the appointments out to everybody. Excuse me a sec while I clear my throat. There's a few more elements, but what I want to do is I want to punt these off to our next call. I want to go over them really quickly, but then I want to go into them in more detail at the beginning of our next webinar. Because I really want to have our brains fresh, and this is a little cruel and unusual to go much more than an hour with a webinar. So a behavioral Center of Excellence is known for achieving results for clients. The organization can measure what's important and achieve excellent outcomes on those measures. And actually, I just want to look at this picture here. It's the almost final piece of information I want to toss your way. So think about your organization fitting into one of two buckets. The first is the work we do makes a measurable difference in people's lives, and we can demonstrate our excellent outcomes and high success rates with data using validated clinical instruments. And then there's bucket two, which is we can't make the aforementioned statement either because we aren't measuring well, but we believe we provide great care, interesting about these two buckets is the second bucket. In the first bucket, there's two things you have to do. You have to be actually measuring whether what you're doing makes a difference with validated clinical instruments, and then and achieving outcomes. And if you're not doing both of those things, measuring and then actually making a difference, you end up in bucket two. So what I want to do next time when we get together is talk about, start out by how the Alliance working together by talking about the importance of working together around what are the outcomes you're going to measure and how you're going to measure them and how you're going to work together to support each other. And the second thing that I want to start out with is excellent value. And I want to go into some detail about the definition of value, which connects to the previous one, and it's very relevant to you guys working together. But I'm gonna wait to do that until we have our next webinar on the 8th or whatever date it was that I said. Sorry, the 9th. So I want to see if anyone has any last questions for today, and then we'll call it a day. Okay, thanks everybody. I'm going to send the slides out. I'll get material out to you in advance. I'll get the meeting invitations out right away, and I'll look forward to working with you face to face after the first of the year, as well as continuing these conversations. And again, be thinking about what's keeping you up at night. If you come up with any more ideas, let me know. I know that Don wrote something about an urgency around how to deal with crisis funding, and Don, I'll be getting back to everybody about that, to folks about that ASAP, because I know that that's an imminent question, and we'll just keep.
In fact, Dale, we have to turn that in by close of business today.
Oh, you did?
To,
so what? So
to the Health Care Authority.
I see. So that door.
Well, I think they say that that's what we have to do, but as you know, we just keep feeding them information, and it does seem to be receptive. So they're receptive about it. So I just want people to know that they are they're very attentive about that right now.
Got it. Okay. Thanks for your time, everybody. Have a great rest of the week. Have a great Turkey Day.
You
talk
too,
to you in
Dale.
a couple weeks.
Thanks, Dale. You too.
Thanks, Dale.
Thanks, Dale.
Bye-bye.